sunny welcome to all you joining us for the third SCRN Interactive Case Discussions. The Interactive Case Discussion Series is a quarterly series of robotic procedures discussed by SCRN fellows and board members. And we are very excited you made it to come and join us today. The Society for Cardiac Robotic Navigation is, as you know, a very active platform and very active in creating and facilitating to spread knowledge about robotics in cardiology and other medical fields. Your discussions here, but also in the annual SCRN meetings and the various joint sessions in main events such as ProgRhythm, HRS, and APHRS are driving innovation along with all the work of our robotic experts and board members. The admission fee to these online interactive case discussions is entirely free of charge, and the duration of this event is about an hour in its totality. We have two speakers today, Dr. Ioan Alexandru Minciuna, Erasmus MC, and Dr. Tamas Torok from University of Szeged and the Erasmus MC, who will discuss their very interesting procedure, new mapping techniques for complex AP. And our moderator this event is Dr. Pedram Kazemian from Deborah Heart and Lung in Browns Mills. We kindly ask all of our participants to keep the microphones muted during the presentations. It makes it easier for everyone to follow along, and we would appreciate if you could switch on your video cameras. During discussions, if you'd like to share an observation, pose a question, or give a remark, please raise your hand virtually with the reactions button in your Zoom control panel. Please wait for the moderator to mention your name, which is your cue to switch on your microphone. Our speakers from today's event will write a case report on their presented procedure and submit it to the robotics section of JFib. You can read all the details after the event there. We kindly ask you to make no recordings or screen captures during the event. This is prohibited. Recordings of this interactive case discussion will be available to all our members on the SCRN website in the SCRN Training Video Service section. Nice to know, perhaps, is that other material from the other annual SCRN meetings are available there for training purposes as well. Today's interactive case discussion, as said, is presented by Dr. Ioan Alexandru Minciuna, who recently successfully completed the EP Robotics Fellows Program. Congratulations. We are very proud to have you as an SCRN member and look forward to your presentation together with Dr. Tamas Torok, who is a well-known expert in the field of robotic magnetic navigation in electrophysiology. They are together presenting on mapping techniques for a complex AP. And if I may now give the word to our speakers, Dr. Minciuna, the floor is yours.
My name is Ioan Alexandru Minciuna. I recently finished the ERA AP Fellowship at Erasmus MC in Rotterdam. And today, together with Dr. Tamas Torok, we will present a new mapping technique for a complex accessory pathway. These are our disclosures. As we all know, atrioventricular reentrant tachycardia, AVRT, is a very common arrhythmia in all EP laboratories. However, some accessory pathways are more and particularly challenging than others. Some of these are accessory pathways with oblique courses, malignant properties, and very important to keep in mind because this will be the most important part of the presentation, accessory pathways with multiple insertions and patients with multiple accessory pathways. So I was saying that the important part of the presentation today will focus on patients with multiple accessory pathways or accessory pathways with multiple insertions. And regarding these last accessory pathways with multiple insertions, these are particularly challenging because they are, of course, frequently unrecognized and associated with the initial catheter ablation failure. And there are very few reports and also limited data on the 3D electroanatomical mapping of these accessory pathways. In a paper published in PACE in 2017, the authors say that in patients where we don't know exactly if there are two accessory pathways or one accessory pathway with one ventricular insertion and two or more atrial insertion, when a single ablation lesion eliminated the retrograde conduction in both pathways, this argues for a single ventricular insertion and two atrial insertion. Also, in other patients, in this case series and review of literature, when the SVT had alternating eccentric atrial activation patterns without alteration in tachycardia cycle length during the catheter ablation, this was another strong evidence of multiple atrial insertion of a same accessory pathway. Also, another study published in Harvard in 2020 recommends as the ablation strategy in these patients either to go, because most of these patients have multiple ablations, 2, 3, even 4 in this case series. They recommend going either strategically for all stepwise for all insertions, or go for the mid-body or ventricular insertion of the accessory pathway. This being said, I would like to present the case of a 43-year-old Caucasian male with a history of recurrent symptomatic narrow-QRS complex tachycardia. We can see it here in panel A. That was referred for an EP study. The ECG, the sinus rhythm ECG at presentation showed ventricular pre-excitation suggestive of a left lateral accessory pathway. The transthoracic echocardiography was normal. An EP study was performed in June 2021 that diagnosed orthodromic AVRT using a left anterolateral accessory pathway. And we can see here on the tracing that the CS shows completely eccentric activation at the beginning. During catheter ablation, here at the earliest retrograde A, we see we have 56 milliseconds earliness. We saw a change in retrograde activation pattern, which made then the operator think there is a second accessory pathway, and then mapping the left lateral mitral annulus and ablating there at the earliest point had acute success. And we can see here in panel C the ECG after the procedure without pre-excitation. However, the patient had early recurrence in the next month, and in January 2022, repeat catheter ablation was performed, which unfortunately was unsuccessful. Considering that the patient had multiple episodes of same 200 beats per minute tachycardia and he was intensely symptomatic under antiarrhythmic drugs, the Erasmus MC EP team decided to perform a repeat catheter ablation using dipole charge density mapping system. The single position, single beat activation map during AVRT showed two quasi-simultaneous early activation sites at the left lateral and left anterolateral mitral annulus, and this could be evident for either for two accessory pathways or for an accessory pathway with two atrial insertion sites. The catheter ablation, where the earliest atrial activation was fused with a ventricular electrogram, led to termination of the tachycardia, and we see here we had 70 milliseconds earliness, and the brown spot is the point where we had success in termination of the tachycardia. And we also see here on the dipole charge density mapping system the exact moment and where the catheter position during the tachycardia termination. What was very interesting, after tachycardia termination, we couldn't induce it anymore, and the new single position dipole charge density activation map showed septal earliest activation, so the activation through the AV node. As much as we tried with aggressive pacing and all the mapping we tried to do, we saw no real retrograde activation through any of the previous atrial accessory pathways. So this made us say at that moment that most probable, considering all the facts and the literature presented, it would be accessory pathway with dual atrial insertion and most probably a successful mid-body ablation. It was no recurrence at 6 months after ablation. This was the first in-human 3D visualization and successful catheter ablation of an accessory pathway with multiple atrial insertion sites using dipole charge density mapping. And considering the alternating eccentric activation patterns without alteration in tachycardia cycle length during the first ablation, the disappearance of both atrial retrograde wavefronts with single shot and the failure of the previous catheter ablation, all this support the diagnosis of an accessory pathway with two atrial insertion sites. And in the next few slides, please let me present some technical details about this novel mapping system, the dipole charge density mapping. This is a novel high-resolution non-contact mapping system which offers superior spatial and temporal resolution and allows the diagnosis of complex arrhythmias based on a single beat. The system is based on a basket catheter, the AcuMap, and its console, the Acutus system. This basket is composed of 6 braces. On each of them, you can see 8 ultrasound transducer electrodes, and between them, the biopotential electric electrodes. All these permit the global atrial to assess global atrial activation maps in less than 3 minutes. And we can see here, we start mapping by putting the catheter in the middle of the atrial chamber, then doing the non-contact, highly accurate ultrasound-based 3D endocardial and anatomy reconstruction using the 48 ultrasound transducers on the catheter. After we have the anatomy already reconstructed, then we create the high-resolution propagation maps with the 48 biopotential electrodes, which are placed between the transducers. The team of Gian-Battista Chierchia from Brussels published in 2021 a feasibility and the technical explanation study, going a bit into the basics of this technique. Each dipole, we can see in here in panel A, each dipole comprising 2 opposite charges, the minus and the plus particles, is generating by the depolarization of a cardiac cell. The summation of these activation wavefronts produced by the dipoles produces the cardiac voltage field, which we see here largely around the charge density. In panel B here, we can see the representation of unipolar EGMs from the charge density here with blue compared to the voltage guided here with red. We can see that the charge density EGMs are sharper and narrower, thus increasing the temporal resolution of the map. And lastly, here in panel D, we can observe that the spatial distribution of the polarization area for charge density map shows an increase in spatial resolution compared to the corresponding voltage-based map. The 2 non-contact mapping modalities of this system consist of single bit, single position mapping. This type of mapping allows us to map any tachycardia in the atrium based on 1 single bit in 1 single position. So we need only 1 bit of tachycardia. And then the super maps, which mean we have to rove with the basket catheter through the atrium. We take different data from different areas of the atrium, and then we overlay the maps and the data and create a higher resolution and superior resolution spatial temporal resolution map. Further, I will present the experience of the EP team at of Erasmus MC under the coordination of Tamas, Szili, Torok, with the DCDM system. This is a study recently published showing the advantage of this novel system for the catheter ablation of brief episodes of ATs. Of course, we all know that those patients that come in our EP lab with some SVTs or after previous ablations, very symptomatic, and in the EP lab with all the isoprol and the aggressive pacing, we can just induce some non-sustained ATs. And then we get very frustrated with all the existing mapping systems, the sequential mapping systems, because we cannot map non-sustained ATs. So then this system comes and we need only 1 beat. So in this type of ATs, when we need only 1 beat to create the map, and then it can help us guide the successful catheter ablation. And this works very well for a brief episode of non-sustained ATs and also for PACs. In patients with very symptomatic PACs, it works very well, again, creating maps based only on one beat. And if, let's say, we are not satisfied with the map, we can create on the second beat another map and then see if the maps show the same. And if they show the same, it means that's the mechanism, so we can go and ablate there. Another important use of this system is in patients with persistent AF. We all know, like, the historical mechanistic concept of AF as self-sustaining disorganized process has been challenged by the concept of localized sources. And this novel system provides the opportunity to acquire panoramic bit-to-bit mapping of atrial activation. And we see here the 3 types of source mapping this system offers. First type of source we can map with it is the focal activation. We see here with purple, with radial conduction around it. Then the most important and the most frequent source we found in these patients, which is the localized irregular activation. We see here with the yellow. That's a disorganized pattern of conduction with repetitive multi-directional, we see towards the red areas, isthmus-like conduction. And lastly, the localized rotational activity, where we have rotational clockwise or counterclockwise activity around a confined zone. And I'm proud to present the results of the new RECOVER-AF study, which came out a couple of months ago only, which showed that in patients which are retreated or re-retreated after PVI or PVIs plus substrate before, the freedom from AF at 1 year is 76%. And in patients that are retreated using source ablation with this system, which had in first procedure only PVI, the freedom from AF goes up to 91% at 1 year, which are pretty good results. Lastly, because we're here at SCRN and I know how important it is using the remote magnetic navigation, studies have also shown the non-inferiority of integration of this novel system, the dipole charge density mapping with remote magnetic navigation, when compared to existing sequential mapping systems. And considering that we have lots of experience with remote magnetic navigation integrated sequential mapping systems, that I think it's a very good thing. So the learning points from these presentations are that one of the best advantages, let's say, that this new novel mapping system brings is that a single bit is sufficient to acquire panoramic atrial activation, and this leads to enormously decreased acquisition time for global chamber activation. And another big advantage is that the map accuracy and resolution are not dependent on the number of points and less dependent on operator experience, because you just have to put a basket in the middle of the chamber and then start creating the map from there. So it allows us creating a more localized representation of the endocardial activation. Before ending, like I said, until now, the most important uses of this system, it already started a new era in mapping and successful ablation of brief episodes of highly symptomatic ATs and PACs with high acute and long-term success rate. It already, as the RECOVER-AF trial a couple of months ago showed, it's already very important in targeting and guiding the ablation of pathology conduction patterns beyond the PVs in persistent AF patients, is non-inferior, integrated with remote magnetic navigation, and also it's a very promising tool for other types of SVTs like AVRTs, like it was in our patient's case, and in the future maybe also for VAs, because we know how much we need a system like this that we can put in the ventricle and map, let's say, hemodynamically unstable VAs. Finally, of course, like any novel system, we have to have also and present the limitations. Further studies comparing this system to sequential mapping are necessary in order to confirm the feasibility and reproducibility of this single bit mapping for patients with complex accessory pathways, and not only. In our case that we presented today, there is some missing data that would have helped us, let's say, be more sure on our diagnosis, and that was that we didn't use 3D mapping in the first two procedures, and also we don't have the CS X-ray images from the first procedures, so then we don't know exactly if the activation patterns we had each time are the same, or this leads to the last limitation, if the previous catheter ablation could have had an impact on the atrial activation patterns. Lastly, as I recently just finished my fellowship at Erasmus MC, and now I'm back home in Romania, I want to thank all the team there, starting with Tamas, with Rohit, Singh, Khan, everybody, Rita. It was a good experience for me. I met wonderful people there. Thanks to all the technical guys beyond the buttons, all the teams that helped me and made this experience possible and increased it day by day. Thank you very much.
Because Ioan finished his fellowship at Erasmus Medical Center. I finished my seniorship at Erasmus Medical Center, so we actually agreed that he will be the only speaker today. I told you this also, Marlus, and he summarized not only the case, but also the scientific background, and I think very wonderfully the technical background of the system. Therefore, I think we can open this nice case for further discussions. And Pedram is with us, I think, and he will.
Yes, that was a great presentation.
Thank you.
Thank you very much, and thank you, Thomas. I haven't received any questions in the chat, so please feel free to type in your question, but maybe I should start first. Now, I was just wondering, looking at your ECG at the beginning, you said this was a lateral accessory pathway, but if you look at lead 1 and AVL, I didn't see any Q waves there. Was it not fully pre-excited, you thought, or was there a different accessory pathway there? And then the decapolar catheter looked like it didn't bracket the insertion site. So was it truly lateral, or was it more anterior and septal than lateral?
Can I comment on this?
Yes, of course.
I think it's a wonderful observation, which obviously shows that it's not a standard accessory pathway. And I think if you think, because the question actually is very valid if you have a single accessory pathway with a single insertion site, and then you expect a kind of standard ECG that you can analyze for the location. But in these cases, and that's exactly the point, and I think Pedram pointed out very clearly that the ECG is probably because of the fusion between the two insertion sites is not typical for any of the accessory pathways that we know actually. So in this case, I agree with you that the previous teams, it should have rang the bell for the previous teams, but I think we can excuse ourselves that we were not the treating teams in the first and the second procedure. And I think that also shows the advantage of this system, that usually I would have a very low threshold to use not only this system, but similar system, let's say multi-electrode high density mapping, or this very high resolution mapping for this kind of atypical, maybe even for first procedures when we see a kind of atypical ECG. But I completely agree. Very good, very nice observation. Thanks, Pedram. But I think it's something to do with the fusion that we had at baseline.
And that the way you did map, use the dipole to map it, this was during SVT or during ventricular pacing?
It was during SVT. During SVT.
Oh, during SVT. Okay.
But I presume, to be honest, it should be this more or less the same on ventricular pacing. However, it might relate to the ventricular pacing site. It was not part of a scientific protocol, so we didn't do very extensive, let's say, the differential pacing techniques. But yeah, you know, this kind of case reports you do mostly retrospectively, yes. And you're happy that you are done at third time.
Yeah, yeah.
But again, I just agree with you. It's very nice question.
Yeah, no, that's perfect. I mean, so the question is that you think these are two separate accessory pathway, or single double atrial insertion with the single ventricular origin?
Look, I think Ioan's made it very clear. The fact that eventually we could ablate with a single shot, and in that procedure we found two simultaneous early activations. It's very suggestive for multiple insertions. And the reason why we brought this case here is just to show the capability of this system in terms of temporal resolution.
Yeah.
Because you really need a very stable rhythm and an extremely high resolution to get to the same spatial resolution. But I think on the temporal, in terms of temporal resolution, you will never get this with standard mapping or 3D mapping systems.
No, it's a fantastic case, actually. It was very good. I know this how difficult these are. You know, we see that sometimes multiple of these ones in patient with Epstein on the right side, actually. And it's very difficult to find where the tricuspid valve actually is, where you want it to ablate, and they're all scarred up in that area. So you have a lot of fractionation that all look like accessory pathway potential if you look at it, but they're not. Some are, some aren't, and they're multiple. So something like this would be fantastic, where you can actually resolve multiple pathways, especially if they alternate. Like you showed the changing in activation sequence of your CS in one of the from the distal to proximal to almost simultaneous. So that's very interesting observation there. But the cycle length didn't change much. I think it was like I forgot, was it 380 milliseconds? So it's interesting. So it's despite the changing of the insertion site, the cycle length stayed the same. So
yeah, but that's why I think Ionuț made it very at the limitations very clear that because you see that retrospectively, obviously. The reason why we use in this case the 3D mapping systems is not to discover this, but rather to get to very high resolution map that can help us to find the best spot for ablation. So I think he made it very nicely and very clear what the major limitations in the interpretation of this case. And it could be that actually they were, that it's still a single pathway and oblique, but the previous ablation actually had this impact activation sequence around the mitral annulus, so we cannot exclude this. But from the take-home message point of view, I don't think it's very important. Actually, it's more important to realize the advantage of having that kind of possibilities for this resolution, because whatever you have, I think it definitely changes your ablation strategy in this case. So you are definitely not going to ablate in this case at the atrial insertion site when they are very much apart from each other. So then you try to go to the mid body, what we always try to do anyway. But in this case, you know that it's far away from the exit site in the atrium.
Just out of curiosity, when you came on ablation, how long did it take for the pre-excitation to go away or tachycardia to break?
I think, Ionuț, you know the exact seconds. I don't remember.
Short seconds, few seconds, okay.
It was a few seconds, and that was during the first procedure. Like that image there with the pre-excitation was during the first procedure. That was also another interesting thing, which I didn't have time there to mention, that after the first procedure, actually, we kept having exactly the same tachycardia, but with no pre-excitation on the ECG.
Oh, okay. So it was conducting orthodromic.
Yeah, only retrograde, yeah.
Okay.
Yeah, we can do nice things in the EP lab.
Hi, here's Sabine. Hi, how are you?
Hi,
great
Sabine.
presentation.
Welcome.
Thank you.
Thank you.
Great presentation. I just wonder if you could go back to show your slides on the acquisition that you made, and if that was done, how you actually technically did this. Did you open the window to annotate until the delta wave? Did you do this in pacing? Do you have the same map also in tachycardia? So you could say retrogradely it activated, let's say, more towards one or the other atrial insertion. Can you show us some or explain some of the different maps that you probably acquired?
But can I comment on this? Because of course you cannot map this you cannot place this catheter currently in the ventricle. So we can map only either during tachycardia or either during ventricle pacing.
Do you see the map?
Yes. So this is during tachycardia, true? Or this is pacing, isn't it?
No, it's during tachycardia.
Okay, I see it on my iPhone, so it's a bit small.
Yeah, I can imagine, but you can see it on the left-hand panel that it's a narrow complex tachycardia.
Yeah, I just zoom it. I just pinch it now with my hands. And okay, perfect. And if
but on the long run, it would be really nice. I don't know when it would be really cool to see at the moment when we will be able to map the ventricle, then actually in this kind of pathways can be even a nice scientific project to see the differences between the atria and the ventricle insertion.
Yeah. So I'm thinking
case, of course,
yeah,
we can't do that.
Yeah, I'm thinking of what is described for the kind of sequential mapping systems and normal, let's say, bipolar mapping systems as the open window technique, where you map a little bit into the ventricle. Actually, Pedram mentioned the challenging cases of Epstein's, and that's actually a very nice technique for those patients to do that with a very small catheter and then high resolution map, but open the window, the annotation window, and just map a little bit into the ventricle. And that would be nice here as well. So just to fake it as, just don't excite the annulus as you did, but, just let the system annotate anything that is there and open it into the ventricle system signal on the surface ECG and see what it shows you. It would be quite interesting just to see, curiously.
Yeah, it's a cool idea, although the problem with Acutus is that it's very depending on the anatomy. But I think they can answer this better if it's possible or not. It's a cool idea, very nice.
Yeah. And for these two atria insertions, you didn't see any different conduction properties, right? So it's on that map, they look pretty similar in the activation timing. Is that correct?
Yeah, and they were similar, like very, very similar there.
And at no point this patient had an alternate in his cycle lengths, right?
I'm sorry?
I just wonder if there was any cycle length. Sorry.
Yeah, the difference, it was in milliseconds, like 10 milliseconds or something like that, like very, very small.
Okay. Because it would have been nice to look at the different cycle lengths, like one, ideally the shorter and then the longer one, see which one is dominating or which is earlier on the insertion.
Yeah, that was also in the first presentation, like the cycle length was 10-15 milliseconds when the atrial activation pattern changed during ablation.
Yeah. So it's, it remains a mystery what you did. You probably hit the mid pathway, kind of where it joins.
Yeah.
And maybe, the other idea would have been to try to pace from the ventricle, take the magnetic catheter across, and then pace closer to one insertion, closer to the other insertion on the ventricular side, just to see what changes. The beautiful thing is that Acutus maps are so fast.
Yeah.
Right. So that would be another idea if you ever come across another case like that.
Yeah, that's a very good idea. I think so.
Yeah, I think the way how I see it is, I mean, we can be very clever after one case, but these cases are meant to draw attention to capabilities. I mean, you start with case and then pilot, and then we can design some studies as well. But at the time when you do it, of course, the major idea is just to provide the best mapping system in order to get rid of this at third time. And it's not like we expect this, but retrospectively or during the procedure, you realize that it's there. So,
if you don't mind, I can keep on asking a couple of more questions. Your choice in going for Acutus and magnetic navigation, what was that kind of formed by? Was that because you felt the stability was better, or how did you come up with that plan?
It's very simple. I try to do mostly the most effective robotic ablation technique that I have in the lab. So in this case, in terms of efficiency, lab efficiency, and especially when we plan something that didn't succeed twice, I usually plan for a very, let's say, detailed but procedure which can be long, but I still want to do it as fast as possible. The last, I think we did the most cases in the world with this system. What I realized that the single bit mapping speed is so much superior on any other systems that that made my decision very easy. So imagine, even if you just focus on one little part, you still want to have very good anatomy using Carto. Don't forget that with Carto, you have only the Carto 6 version, and the best case scenario, Pantherate catheter. So it takes quite a few minutes. And then imagine if you want to do maybe 10, 15 maps during the procedure, then it's very lengthy. So in this case, it made for us very easy. The other reason why I like to use this is the availability of the ablation catheter with a gold tip. So it is almost like, I don't know how many of you does high-level sports, but in our skeletal muscles, we have different kind of muscle fibers. So it is impossible in terms of during an exercise to separately activate those muscle fibers. They are all activated at the same time. It's the same with this kind of thing. So if you want to achieve success, actually, I don't know what happened in the first cases. Why was it unsuccessful? Was it because of the diagnostic error, or was it because of a good diagnosis, but an inappropriate lesion formation? And that's why I think at the end of the day, for these cases, I use a kind of triple gun. Presence of robotics, which gives the best stability. Then I have a catheter in which that in my hands, I think performs in RF delivery better than any other catheters with a gold tip, and that's the only one which is available. And that can be used with an Equitus system, which has a very high resolution. So these were the most important factors in the decision-making algorithm in this case.
I think there's a very good argument for the use of magnetic navigation to have the precision and the stability to do these ablations and map with very small increments. And of course, you did the transeptal approach here.
Yeah.
Can you say just how much energy? How did you? What was your flow, stuff like that, like a technical settings for the ablation?
Jonas, you know it better again than me.
Yeah, I remember. I don't have now the technical details, like I didn't look now on them, but I remember the flow was 20. And
we use usually high energies of 50 watts, 55 watts.
55, yeah.
Excellent.
And one more addition to this. So when I do ablations without mapping systems, standard SVTs, I always use this MedFact MagnoFlush catheter instead of the other available catheters.
And
even
that would be more or less your standard.
Even in children, I use this catheter.
Yeah, and that would be your standard setting for kind of SVT ablations, or?
For pathways, yes. For AV nodules, of course, we are more cautious and we do slow up titration.
Yeah, non-irrigated.
Super. Okay. When you say just because you said non-irrigated, do you lower the flow or do you use a different catheter, or
No, there is no different catheter, so we do it as you said. So we just put it on 2, and we cheat the system saying that it's a non-irrigated catheter.
Yeah.
It remains
cool. That's maybe something to share as well, how you set that up and make sure that this doesn't share. Perfect. So I think I'm done with my questions. Thanks a lot. Great case.
Thank you very much.
Thank you very, very much. These interactive case discussions are always a lot of fun, and we hear from our presenters that it's a good practice in presenting and gives the opportunity to broaden your network. In case you are now in the audience and thinking you would like to present an interesting robotic case, then feel free to send us an email at contact@scrn.eu with your topic, and we would be happy to plan you in for one of the next year's interactive case discussions. We will hold them in January, April, and July, and more information will soon follow. It would be great if you could be one of our next presenters. Then there are many benefits to becoming a member of SCRN, especially for fellows. You get a discounted rate of only $30 for 2-year membership. That is a great deal for getting pre-registration priority for the annual SCRN meetings, to nominate for SCRN board membership, and getting access to the video training services. With your membership, you support high-quality educational events such as these and the annual SCRN meetings, as well as an innovation in the medical fields. Additionally, SCRN is supporting robotic EP fellows this year with a limited number of travel grants for the 7th annual SCRN meeting in Washington. Should you wish to be considered, send us your CV and motivation to contact@scrn.eu, and through a vetting system, EP robotic fellows will be selected for grants. 7th annual SCRN meeting is online now and can be registered via our website. The program is published, and perhaps our organizing committee, represented by Dr. Pedram Kazemian, would like to say a few words on the amazing program the SCRN is putting together.
Yes, thank you very much for your introduction. This is a very exciting annual event that we've had for now, coming for 7th year. And it's gone through different iterations, but we invite leaders in the field who use cardiac robotic navigation, but also people from other fields that use robotic in their respective specialties, pulmonology, interventional cardiology. And we take advantage of their expertise and how they implemented the robotic in their field. We also have people from industry who will come and tell us about upcoming devices, areas that the future holds for us. So this will be exciting for everybody who's interested in cardiac robotic, and I'm sure everybody who participated in today's case interactive session is. So I highly recommend participation, and we also have fun events, get together, networking for the fellows. So this will be worth your while if you could participate in person, but we also have the opportunity for remote participation for those who cannot in person participate.
Thank you very much. The next event is on the 2nd of September, which is a joint session between APHRS and SCRN. We are very happy to share this news with you, that there will be a live connection from APHRS in Hong Kong, and there will be a connection to the robot in China. Keep an eye on the APHRS program for more information that will follow soon. The timing of the event is the 2nd of September, 10:40 Hong Kong time until 12:20 Hong Kong time. After all this information, leaves me nothing but to thank our speakers, Dr. Ioan, Alexandru, Minciuna, and Dr. Tamas, Szili, Torok, and of course our moderator, Dr. Pedram Kazemian, everybody who participated in the audience today. Thank you very much. We look forward to welcome you soon to one of our events and wish you a very pleasant continuation of your day. Thank you and have a nice day.